right, we're gonna talk about the second gas lecture, the second gassy lecture. Okay, so so we talked initially about the how to interpret the gas, and we talked about how to we talked about some complicated gases and how and concepts and stuff like that. We're gonna start with acute or respiratory alkalosis. That's the easiest one to talk about because it is actually. It's basically anything that will make your brain excited. So if you're thinking about causes of acute respiratory alkalosis, you can make this as much as easy as you can. Number one is anxiety or pain. Number two, anything that will make you excited, meningitis or encephalitis. Encephalopathy, including hepatic encephalopathy or uremic encephalopathy or any type of encephalopathy make you breathe faster. Hepatic encephalopathy is a classic. It will actually give you a pH in 752 to 752 to 755 range all the time. Don't try to correct it. It's not going to correct. It will only correct when you correct the cause. It might be actually physiologic. It might be that the brain is doing this so it decrease the CO2, and that will decrease the cerebral blood flow, and that will decrease the ICP. So leave it alone. Just correct the cause. Number four, when I was young, my attending had me scavenge small pieces of vent tubings to add them to the dead space of the vent. So we can force this guy to correct his gas, to build more dead space. And you know what the guy did? He just breathes faster. He had to achieve this. So intracranial hemorrhage or intracranial tumor. Number five, PE. And number six is salicylate toxicity. Right? These are the things that will actually give you respiratory alkalosis. Nothing outside of this list. Barely you can see things outside this. Anything that will make you excited. So let me give you a couple of examples here or cases. So I was attending from home. The resident called me and said, we have a patient with Ativan overdose. We need to admit him to the unit, put him on BiPAP. Do you think we should give him flumazenil? I said, no, come on, I'm not going to give the guy flumazenil. We already brought him to the unit. Let's just wait on BiPAP until he wakes up. 70-something years old. Get a gas only before we start to see if he needs to be intubated or something. So anyway, I talked to the same resident about 2 hours later, and he updated me about the first case, and he said, he came in. I said, what's the gas? He said the gas was like this. What's wrong with this picture?
If he has benzodiazepine intoxication, he should have hypopnea and respiratory acidosis with it. This is a classic, did we scan his head?
So basically, this one is what? We'll take it the same way we dissected the gas before. 752, that's alkalosis. Is it respiratory or metabolic? It's respiratory. Is it pure or mixed? This went down by 8. That will result in a change of 0.07. So the gas should have been 747 from the change of the PCO2 that happened. But in addition, there is something else, which is metabolic alkalosis. This went from 747 to 752. So we have respiratory alkalosis and we have metabolic alkalosis. We have no acidosis whatsoever in this guy. Right? How can it be?
It's PCO2, it's a decreased PCO2 by 10.
Results in a change of the pH of 0.08 in the opposite direction. So there's no acidosis. So we initially went in the mode of we have to rule out what's happening here. And as you said, we have to scan his head. We scanned his head, he has intracranial hemorrhage.
Wow.
Right? So if you make up the whole story from the beginning. So then I asked the resident, how much Ativan do you give him? He said 0.5. I said, that is not an overdose. So in any case, that's what happened, right? What happened is that the guy came in with UTI. He was sitting there doing nothing. and then suddenly something happened, he bled in his brain, so he became agitated. So the nurses came and gave him 0.5 of Ativan.
Yeah.
And of course, we always underestimate the effects of sedatives on the injured brain. It's different than the normal brain. The pharmacodynamics are different. The kinetics are okay, but the dynamics are different. So he just went to sleep completely with the 0.5 Ativan, so they blamed it on Ativan. So of course, if we had this guess from the beginning, we would have at least saved 2 hours on this guy. All right, to give you another guess, another story. So the resident went down to evaluate the patient in the ER, and he came to me and said, the patient looks like a peach. We should send her to the floor. With only one problem. The problem is, this is her guess. 7.8, 11. I said, who is going to accept this patient on the floor with this guy? Nobody's going to accept this. We have to decipher what's going on here. So what's the story? The story is that the patient is breast cancer patient, metastatic breast cancer. She's on chemotherapy. She's emaciated. His hair is lost. Everything looks like a chemotherapy patient. And she came in for weakness, and they set the gas, and that's what they found. So I was sitting there pontificating, crossing my legs and saying, it must be a metastasis. It must be that she just had metastasis. She looks like metastasis is waiting to happen. So let's send her for a CAT scan. CAT scan is negative. So the patient came to the unit, and then we said, okay, well, maybe the CAT scan didn't show the small metastasis that just happened today. Maybe it's a posterior fossa metastasis, which is really very difficult to see with a CAT scan. So we'll send her for an MRI. Send her for MRI.
Nothing.
Negative.
Yeah.
So then we said, oh, shirikaka, it doesn't look good. How about if she's hypercoagulable? Maybe she's hypercoagulable, and maybe she, because of the cancer, and we'll do what we're gonna do. We're gonna do, we will do a CTPE, right? So we did a CTPE, and it's negative.
Yeah.
So it was like, we are gonna cry now. There's something going on. So we thought of something. We obviously sent ammonia level, we sent aspirin level, and looked at the patient. Patient doesn't look like even she's in pain or anxious or anything. So we looked, and the only thing we can how are we drawing the gas? So imagine if you're sitting there doing nothing, and somebody comes in, a green respiratory therapist just graduated, and he goes in.
So every time we draw the gas, she's
Yeah. So what's gonna happen? You're gonna be screaming, right? So what we did is that we did an A-line. We waited a couple of hours,
Right.
and we did a gas. It turned out to be 755. So we sent her to the floor, which after wasting thousands of dollars on this patient. Which brings me to a very important concept, which is the concept of. You heard the term of you can never overcorrect with the compensation.
Right.
It's always been said is that you can never overcorrect.
the
Meaning,
body won't.
yeah,
overcorrect.
why would you overshoot? The body is not crazy, So if you have metabolic acidosis, your pH, your PCO2 is gonna go down, and your pH is gonna go up, but it will never go up above 7.4, right? That is true if you're drawing the gas from a central line or from A line. If you're drawing it with the way where you injure the patient and hurt the patient, you might overcorrect. So you have to accept it. For example, I've seen people pontificating on this, for example. 28, 742, 28, lactate of 5. And they tell you it's acute respiratory alkalosis first, and the lactate is another disorder. No, it's different. The lactate is still the primary cause. This patient was probably sitting at 738, 31 or 33, right? And then, but when I go in and did that, he breathed a little bit more and dropped his PCO2 and raised his pH a little bit. So you can accept a little bit of that if you're drawing the gas that way.
Yeah.
And that is it. That's it.